Hello, I'm Randy, and I'm sitting in on Tina's presentation.
Hi, I'm Blair, and I'm sitting in on Tina's presentation.
Hi, I'm Tina Massey, and I did my presentation on the benefits of clinical integration. Because of the rising cost and declining reimbursements of healthcare, it's necessary to find a way to reduce costs while at the same time improving quality. The government's decision to shift Medicare reimbursements from volume to value by 30% at the end of 2016 and tie another 50% of payments to these models by the end of 2018 is motivating healthcare systems to figure out how to best reduce costs, improve quality and care coordination, and assume risk for patient populations to remain relevant in today's market. Although there are a lot of definitions, the one that I thought was the best definition that captures the essence of a well-built program comes from the American Hospital Association. The AHA defines clinical integration as a program that is needed to facilitate the coordination of patient care across conditions, providers, settings, and time in order to achieve care that is safe, timely, efficient, effective, equitable, and patient-focused. To achieve clinical integration, we need to promote changes in provider culture, redesign payment methods and incentives, and modernize federal laws. Today, there is no linkage of the services from hospitals and healthcare providers. Hospital inpatient and outpatient services, laboratory, diagnostic imaging centers, and all other ancillary services are separate services, and they all work independently. It's kind of like putting a puzzle together. Examples, a really good example I found was if you had a patient who's seen by a specialist and the information from that visit isn't readily available, or sometimes never reported to the primary care physician the next time the patient's seen in the office. So how can the primary care physician do the best for that patient without knowing that patient's history or any issues that patient may have? This creates a lot of problems because maybe also that specialist prescribed medications that the primary care physician doesn't know about. And then the next time the primary care physician may be prescribing something that counteracts with that medicine. So the primary care needs to know what medications and what services the patient has obtained since their last visit so that they can provide the best care possible. Another situation would be ordering blood work. Sometimes your primary care orders blood work. Sometimes your specialist may order blood work. I know myself, I had my endocrinologist orders certain testing that she wants to find out about blood sugar levels, vitamin D, thyroid medication, that type of stuff. And if you go to a Quest or one of the labs, insurance companies sometimes won't pay if it's duplicate testing within a certain amount of time, or the same amount of time. Sometimes they only pay like every 30 days or not 30 days, probably every 90 days. So a lot of times you also have to fast before having the blood work. So who is that inconveniencing? It's inconveniencing you, it's unfair to the primary care, and you're not receiving the best care that you possibly could have if the care was better coordinated. Benefits of a clinical integrated program. Benefits not only the healthcare system, the primary care physicians, all of the physicians, and the patient, and which would be best for the community as a whole. Some ways that happens is physicians are able to collectively select clinical measurements against which they will be evaluated, demonstrate quality to patients, take advantage of technical and infrastructure support from the network, retain independence or current practice structure, and enhance revenue through a variety of unique payment methods. The benefits for patients are also enormous, since they no longer have to go to several places to obtain information. Their primary care physician has all the information at their fingertips. This is usually done in the form of like a dashboard, kind of like if you think about an app that you have on your iPhone. They can manage the patients as carefully and effectively as possible and provide continuity in the patient's relationship with their physician and the hospital. They will receive more reliable information to support their choice of healthcare plans, physicians, hospitals, measurable outcomes, which leads to a better value for money spent on healthcare, which the dollar comes from all areas. Health systems or provider networks can rely on a network of skilled physicians who are determined to provide patient outcomes through evidence-based best practices. They're all working together for the same goal on the same measures. They can reduce admissions rates and lengths of stay, better utilization of resources to provide a continuum of care across the system. Employers benefit because they can purchase efficient healthcare services for their employees, receive increased employee productivity and reduce absenteeism through better management of patients or employees that have chronic diseases, and they can pay less for those services since there will be lower cost over the long term through the reduction of unnecessary services. Insurance companies can now target how healthcare costs are spent and see where they have been lowered. They can clearly define and track the health and wellness of the population they serve. As you can see from the above benefits to all benefactors, clinical integration provides more effective care management for the patient, increased collaboration, more informed payer partners, and improved case management, patient-centered communications, improved pharmaceutical management, and improved health of the community overall. Some of the hurdles involved in developing a clinical integrated network or program, it does require significant cash outlay, so a large amount of cash and a great amount of infrastructure. It also requires 100% commitment from the physicians. The physicians must be championing the program or it's not going to work. They are at the forefront of implementing the measures and the performance is paramount. There are several key elements to establish a clinical integrated program. In order to legally implement it, you need the Federal Trade Commission, sign off or blessing. So there's a lot of government stipulations, government red tape, hoops you have to jump through, and certain things you have to make sure you're doing, and it has to be perceived as, or it must reduce cost, but you must also have better quality for your members. You also have credentialing criteria and participation agreements that outline the participation criteria, sensitive information technology adoption, for data and information sharing, utilization requirements and measures, and of course incentives to increase compliance. So physician agreements and physician contracts of all sorts in place with each of the moving parts. Third requirement is to have care management plans and quality measures for physician performance. Fourth would be a good quality monitoring program or data warehouse that gathers all the information from all the providers to monitor program quality, which requires connectivity between all the provider offices. And currently that, is a problem or proved difficult to do because every office may have a different program. There's a bunch of different programs out there, cloud-based, non-cloud-based. There's as many as there are different types of computer manufacturers, Dell and Gateway. There's also, sometimes you might have two platforms. You might have a billing platform and an electronic medical record platform. They might not be all on one platform. So the systems themselves don't talk to each other. So you would also need to have the payer contracting options for self-insured employer group contracting. So you would need to contract with insurance companies, employer groups. You need to capture some Medicare patients and a good, portion of your market share. There's some options to consider. Physicians and hospitals, first, foremost, they could do nothing at all. They could just keep doing what they have been doing. They both maintain current strategies based on fee-for-service payment, avoid upfront cost of care coordination, and take their chances on the declining reimbursements. And those changes I discussed earlier from the from Medicare, indicating that most of the reimbursements are moving to some type of pay for performance, so they're going to be behind the 8 ball. Potential pitfall, are they'll take home less pay, and hospitals will also see their margins shrink. And how does that benefit the community? Another choice is for hospitals and physicians to work on improving care coordination, but within their individual silos. A hospital could use, quality methodologies and technologies, which I'm sure they probably already have a lot in place, and I'm sure physicians have, the same type of, quality improvement going on in their offices. But they could develop a medical home to coordinate care, or independent coordination would enable each party to leverage gains in payer contracting, but they won't be able to point really to cost reductions, and physicians won't be able to claim better chronic disease outcomes. The problem is that neither the hospital nor the physician will realize the benefits of a fully coordinated patient care program. So their opportunities for success under value-based contract model will be limited. So the conclusion is that clinical integration is the best way to go. It is the best strategy, is to have one where you build a platform for hospital and physician collaboration that is flexible enough to support a broad range of possible futures. Both hospital and physicians have many options for taking advantage of new payment models. However, clinical integration represents the best opportunity for parties to work together on a solution. Without transparency of healthcare, high prices and wasteful care cannot be corrected. By tracking the practice patterns of individual physicians, high-value providers can be identified and rewarded accordingly. By providing physician practices, clinics, and hospitals with detailed feedback in respect to practice and referral patterns of individual practitioners, costs can be better managed. These alternative payment models make healthcare providers more accountable for the quality of care they deliver to patients. Currently, providers receive a payment for each individual service provided, and it doesn't matter if these services help the patient. They still get paid. The alternative payment models provide a financial incentive to coordinate better care for their patients. A platform cannot be built overnight because, as you can see, there's a lot of different pieces and a lot of money that needs to be spent putting a program together. They need to work together and have some type of governance structure, clinical programs, care management, contracting mechanism, infrastructure to have an effective program. Clinical integration should not be conceived as a project with a defined end. Instead, it should be perceived as an evolution that will require ongoing attention, quality improvement, resources, and significant physician leadership. The benefits to the patients and the community as a whole are vast with clinical integration. Thank you very much.